Bismillah ar-Rahman ar-Rahim. It's my pleasure to be with you again to continue our lectures about the challenges of COVID-19 in nephrology. We started the first lecture with an introduction about the virus, the mode of transmission, the structure of the virus, and the recommendations regarding the regular hemodialysis patients and dialysis patients in hospitals. And now we will continue with the recommendations and challenges regarding the kidney transplant patients and autoimmune patients, and some new updates about the ongoing trials for medications to be tested for this outbreak. For kidney transplantation challenges, it is unlikely that there will be staff and hospital resources during a pandemic for kidney transplantation programs to be operated, given the multiple personnel involved in a renal transplant and the pressure load on the hospital facilities, so especially ICUs, beddings and hospitalization, and the operation theaters. All this will make it a very big load to go on with such elective procedures in the area of the pandemic. So usually the operations which are cold and non-life-saving, including transplant operations, will be temporarily suspended. The patients will, in the immediate post-operative, are over-immunosuppressed after kidney transplantation, and this by because they take huge or tremendous doses of immunosuppressive drugs, which reduces the ability of the immune system to fight the infections. And it's important to keep taking these medications, and or otherwise the organ will be rejected. So you have to, so that's another reason why we should reduce or hinder or suspend the transplant operations temporarily. What about the people who already have kidney transplants? Again, those people are maintained on immunosuppressive medications to prevent rejection of their organ. So it is important to emphasize that the patients will keep on the medications. They should not stop these medications, but we as transplant physicians should be meticulously keeping the doses of the medications at the lowest possible dose that maintains the organ without over-immunosuppressing the patient. So tedious adjustment is a mandatory procedure in this case. Again, we should emphasize that all patients should maintain good hygiene, wash hands, self-isolation, and follow the recommendations from healthcare team. These are the recommendations for transplantation recipients who are diagnosed with COVID-19. If you have normal kidney function tests and they are in home quarantine, therapy with levofloxacin rather than azithromycin is recommended after careful evaluation by the physician to avoid drug interaction with calcineurin inhibitors, which might require empirical reduction, because we all know that azithromycin is hepatic microsomal enzyme suppressor. So this might require to reduce the dose of calcineurin inhibitor to prevent calcineurin toxicity. Adequate hydration and the use of paracetamol in case of fever. For non-hospitalized patients, maintain the least possible dose of steroids if the patient was on a steroid-containing protocol, or if the patient, or you can space steroids, make it every other day or whatever. The important thing is to reduce steroids as much as possible without jeopardizing the graft, to give the opportunity for the innate immunity to become more potent and to combat the virus. For hospitalized patients, steroid use is controversial, so it is suggested to apply the most conservative measures possible regarding the use of steroids. In some instances, it has been suggested that calcineurin inhibitors and mTORs can be discontinued and replaced with the protease inhibitors, lopinavir and ritonavir, suggested as treatment of COVID-19 to avoid potent drug interaction between them. Yet, the benefit of these medications, the lopinavir and ritonavir, is not yet confirmed for COVID-19 treatment, so it is not wise to stop a medication that is desperately needed to maintain the graft functioning well, to give a medication which is not yet proven that it has any effect on COVID-19 and still under trial. So what we do is to continue on the immunosuppression, reduce the dose to the least possible according to the drug monitoring and the leveling of the immunosuppression medications, whether calcineurin inhibitors or mTORs, and instruct the patient to take the antipyretics and good hydration with possible antimicrobials that is not harmful or not interacting with the immunosuppressive medications. What about the donors? The risk of acquiring COVID-19 from organ donation is low. However, due to high affinity of SARS-CoV-2 for the kidney, where it has been shown to replicate in almost 30% of COVID-19 patients, screening for the virus in kidney donors should be an important issue. Also, donors who show symptoms or have traveled in high-risk areas should be asked to postpone donation for 14 to 28 days. These are the American Journal of Transplantation published online on the 23rd of March, the last 23rd of March 2020, courtesy to Professor Hussein Shaisha, Hussein Shaisha Mansoura Kidney Institute, who showed these data on the virtual COVID-19 meeting, Mansoura and Egyptian Society of Nephrology and Transplantation meeting. Here we can see the summary of donor and recipient screening practices in some countries. In Canada, the universal nucleic acid testing we'll speak of course about living donors. In Canada, universal nucleic acid testing for donors should be done, and the pre-transplant recipient screening only clinical, and the specimen should be taken for these patients or donors nasopharyngeal or by bronchoalveolar lavage. In Italy, the same, but nasopharyngeal lavage in living donors only, nasopharyngeal swab in living donors. In Spain, again, besides the universal nucleic acid testing, they postponed all the procedures for 3 weeks if the donor was known to be exposed to a patient with COVID-19. In Korea, the same. In Japan, they made self-isolation or hospital admission for 14 days prior to surgery for the living donors, and of course they did the nasopharyngeal swabs for patients and donors, or bronchoalveolar lavage for those patients who, if they were intubated or for any reason, or for deceased donors, sorry. So, as we see, that testing of the donor will become a crucial issue for most of the transplantation schools around the world, and they all instructed to take the nasopharyngeal swab for nucleic acid testing before going to transplantation, and the patients also should be tested before receiving the huge immunosuppression medications given to those who will undergo kidney transplantation. Again, this is also the ambulatory transplant clinic service reduction during COVID-19 pandemic. The more there is infection rate, the more you should go on and do more reduction of the services that you should give as an outpatient clinic. So in the beginning, you should reduce the cases who have stable graft. They come only for just routine checkup. Those also should be instructed to do the investigations outside in the hospital, not to do it in the hospital, to reduce the load on the hospital. If the infection rate becomes higher, you go to 50% reduction on transplant activity, and we only see those who are who were recently transplanted, or those who have subacute or chronic complications, and we should consider in all times the telehealth, which will be the new era in medicine after COVID-19. Again, when the condition of the infection in the community worsens, you should reduce the outpatient clinic services to 75%, and transplant patients with acute complications only should be seen and admitted. If there was a 100% reduction due to the stage 3 or the flare-up or the peak of a local peak of the pandemic, all ambulatory activity should be deferred and stopped, and patients, if they need any interaction, should be referred to other places if possible. Again, the transplant activity here, as we said, this is more detailed. 25% no operations for those undergoing living donor activity. As we said, that this will overload the facilities of the hospital, and no need to do such hassle for the hospital in this cold procedures. They all emphasize that there is no need for doing any living donor transplants, kidney transplants in this period. What about autoimmune disease patients' challenges? People with an autoimmune disease may be prescribed certain immunosuppressive medications depending on the disease and other factors. These medications work by keeping the immune system less active, which can make it harder for the body to fight infections. During the SARS-CoV infection in 2003, the WHO recommended avoiding the use of steroids due to their potential inhibition of viral clearance and the prolongation of the duration of viremia. However, whether this is also the case for SARS-CoV-2 is currently unknown. For this reason, we suggest maintaining the most conservative measures possible regarding the use of steroids. AKI, acute kidney injury, and the contribution of angiotensin-converting enzyme 2 expressing organs in SARS-CoV-2 replication and infectivity. The angiotensin-converting enzyme 2 expression has been reported in alveolar cells in the lungs and the other organs, including the kidney, the heart, and the gut. It is not confirmed whether excessive ACE2 expression in these organs affects SARS-CoV-2 infectivity or not. Yet, the finding that acute kidney injury, cardiac damage, and abdominal pain are the most commonly reported comorbidities of COVID-19 suggests that SARS-CoV-2 may have a tropism for these organs. AKI was identified as a fatal complication of SARS, given that almost 92% of SARS patients with AKI died back in 2003. Diao and colleagues published their findings on March 2020, where they examined the viral nucleocapsid protein in situ in the kidney post-mortem and found that SARS-CoV-2 antigens accumulated in kidney tubules, which strongly suggests that SARS-CoV-2 infects the human kidney directly, inducing acute kidney injury and contributing to the avid viral spreading in the body. The difference between the higher renal affinity of SARS-CoV-2 compared to SARS-CoV infection 2003 could be explained by the increased affinity of SARS-CoV-2 for ACE2 following allowing greater infection of the kidney, which may act as a viral reservoir. So should we stop angiotensin receptor blockers for SARS-CoV-2 infected patients? It's not a simple answer, especially based on current knowledge. There is a paradoxical effect of angiotensin converting enzyme 2 modules or modulation in the outcome of COVID-19 infections. First, that 2/3 of patients who died from COVID-19 had diabetes or cardiovascular disease, and most of these patients were treated with angiotensin receptor blockers. Studies showed that angiotensin receptors blockers increased angiotensin converting enzyme 2 expression in the kidney and the heart 2 to 5 folds, yet there is no evidence for the lungs, but it's most likely that angiotensin receptor blockers can increase ACE also in alveolar cells. ACE2 طبعا. Preclinical studies showed that ACE2 is significantly down-regulated in different animal models of severe lung injury. Nevertheless, ACE2 upregulation by angiotensin receptor blockers is found to be protective during SARS-CoV-2 infection, which is, again, a weird finding. 6, although angiotensin receptor blockers increase the angiotensin converting enzyme 2 expression in the lungs, we do not know if this increases shedding rate of angiotensin converting enzyme 2 with a consequent increase in soluble ACE2 that would act as a decoy receptor buffering circulating SARS-CoV-2, limiting viral entrance in target cells, simply because it will compete with the virus to the angiotensin converting enzyme receptors. So it reduces the ability of the virus to bind to the lung cells. It has been shown that administration of recombinant ACE2 is beneficial in respiratory syncytial virus infection in mice. Whether this could be valuable for COVID-19 patients will become clear from the ongoing open-label randomized controlled pilot study, clinical study called NCT 04287686. The generation of angiotensin 1 to 7 from angiotensin 2 by ACE2 can create a cytoprotective environment within the lungs, which counterbalance vasoconstriction and pro-fibrotic processes, a key protective mechanism during coronavirus infection, consistent with the protective role of angiotensin converting enzyme 2 in acute lung injury. In the Clinical Journal of American Society of Nephrology, there is a very interesting article about sound science before quick judgment regarding RAS blockade in COVID-19. And this is a very nice diagram showing potential effect of angiotensin converting enzyme inhibitors and angiotensin receptor blockers on severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, induced alterations to renin-angiotensin system pathways. SARS-CoV-2 binds to ACE2 via its spike protein and induces internalization and shedding of ACE2, leading to increased angiotensin 2 and decreased angiotensin 1 to 7, with increase in inflammation and fibrosis. The red sign as shown on the left cell. Relative to anti-inflammatory and anti-fibrotic actions the blue cells on the right side. In the left panel, there is no angiotensin converting enzyme inhibitor or angiotensin receptor blockers. In the right panel, this patient receives angiotensin converting enzyme inhibitor and or angiotensin receptor blocker, which diminishes the effect of angiotensin 2 and increases angiotensin 1 to 7 effects, leading to attenuated inflammation and fibrosis. And as you can see here, the dashed inset in the right panel refers to theoretical increase in cell membrane expression of angiotensin converting enzyme 2 with angiotensin converting enzyme inhibitors and or ARBs use. So this shows that the use of angiotensin receptor blockers and angiotensin converting enzyme inhibitors could be protective rather than harmful. From all the above suggests that ACE2 angiotensin converting enzyme 2 in the lungs may play a protective role in SARS-CoV-2 infection. These considerations limit the concerns of nephrologists regarding whether or not to discontinue angiotensin receptor blockers in COVID-19 patients with diabetes and hypertension. Besides, during Ebola outbreak in Sierra Leone, it has been reported that treatment with angiotensin receptor blockers improved the survival of around 100 patients. ARBs also associated with decreased mortality in pneumonia patients. Another important recent observation that ACE2 receptor abundance decreases in the elderly in all tissues, placing them at a greater risk of severe illness, and large studies will be required to evaluate whether inexpensive and widely available ARBs may have a therapeutic potential also in COVID-19 patients or not. This is a very interesting article in the Lancet about COVID-19 and what we call cytokine storm syndrome and immunosuppression. It's a very important issue for all nephrologists to know. Aslay and al. Investigated the presence of SARS-CoV particles using electron microscopy in renal specimens from post-mortem SARS patients with AKI. They found that SARS-CoV was not detectable in any of the analyzed patients. We are talking about SARS-CoV, not the COVID-19. This was in 2003. And suggested that renal impairment was likely related to multi-organ failure. They further suggested that AKI in SARS patients could be the result of specific pathogenic conditions, including cytokine release syndrome, rather than active viral replication in the kidney. Indeed, increasing viral infection in alveolar cells results in massive recruitment of immune cells, which produce large amount of cytokines, causing multiple organ failure. This was discovered by subsequent study that showed that an interferon gamma-related cytokine storm was induced post-SARS-CoV, leading to severe organ damage in SARS patients. Whether cytokine release syndrome is also a feature of SARS-CoV-2 infection leading to AKI as in SARS is not known yet. What has been shown so far that a specific inhibitor interleukin 6, the major driver of cytokine release syndrome, appears to be beneficial in severe COVID-19 cases. This drug, tocilizumab, which is interleukin 6 inhibitor, has been approved by the by the US FDA for the treatment of rheumatoid arthritis and is now under investigation in a randomized controlled trial in China involving 188 patients with COVID-19. As for the novel coronavirus, a recent study reported that the human kidney is a specific target for SARS-CoV-2 infection. In hyperinflammation, immunosuppression is likely to be beneficial. Reanalysis of data from a phase 3 randomized controlled trial of interleukin-1 blockade, anakinra, in sepsis showed significant survival benefit in patients with hyperinflammation without increased severe adverse events. A multi-center randomized controlled trial of tocilizumab interleukin 6 receptor blockade licensed for cytokine release syndrome has been approved in patients with COVID-19, pneumonia, and elevated interleukin 6 in China, as we said. Janus kinase or JAK inhibition could affect both inflammation and cellular viral entry in COVID-19. All patients with severe COVID-19 should be screened for hyperinflammation using laboratory trends, example increasing ferritin, decreased platelet count or erythrocyte sedimentation rate, and the H-score to identify the subgroup of patients for whom immunosuppression could improve mortality. The therapeutic options, including steroids, intravenous immunoglobulins, selective cytokine blockade, example, anakinra or tocilizumab, and the JAK inhibition. This is the H-score for secondary HLH, which is shown here using the number of cytopenias and giving them scores, temperature scores, organomegaly scores, fibrinogen with scores, and other acute phase reactants, ferritin, the serum transaminases also have scores, hemophagocytosis on bone marrow aspiration, again with a score, and known immunosuppression, if the patient is taking immunosuppression or not. So, the H-score generates a probability for the presence of secondary HLH, which is the hemophagocytic lymphohistiocytosis. H-score greater than 169 are 93% sensitive and 86% specific for HLH. Note that bone marrow hemophagocytosis is not mandatory for diagnosis of HLH. H-score can be calculated using an online H-score calculators, and it's very beneficial and gives an idea about whether or not the patient will benefit from a steroid intake or not. A quick look at about some hot topics. We all heard about the role of chloroquine and hydroxychloroquine in the management of the COVID-19 infection. Actually, there is some important data about this topic, and it showed that the chloroquine and hydroxychloroquine inhibits viral replication and reduce the disease load on the patients. Yet some of them, especially the chloroquine, has some serious side effects, so they should not be used unless with close monitoring by their physician. Chloroquine phosphate, it increases endosomal pH, affects viral cell fusion. The dose is 500 milligram BID orally for 5 days, and we should check for drug-to-drug interaction, prohibit to combine with the drugs that may lead to prolonged QT intervals such as moxifloxacin, azithromycin, and amiodarone, etc. Hydroxychloroquine proposed mechanism hampers the low pH dependent steps of viral replication, and no renal or hepatic dose adjustment needed. The side effects again is the long or prolongation of the QT. Dose 400 milligram PO twice daily first day, and then 200 milligram PO twice daily for 4 days. And for pediatric patients, 6.5 milligram per kg dose per dose every 12 hours for first day, then 3.25 milligram per kg per dose every 12 hours for another 4 days. The tocilizumab we were talking about, it's an interleukin 6 inhibitor. FDA has approved starting a phase 3 clinical trial. Side effects include elevated transaminases and might activate other respiratory tract infections. Kevzara, sarilumab, another rheumatoid arthritis treatment that blocks interleukin 6 receptor, being explored in US-based phase 2 to 3 clinical trial. for the treatment of severe COVID-19 patients. The take-home message: avoid unnecessary exposure and keep social distancing and or self-isolation. When you go out in public, keep away from others who are sick, limit close contact, wash your hands, avoid crowds as much as possible. During an outbreak in your area, stay home as much as possible. Dialysis patients should not miss sessions. Kidney transplant patients should keep taking their anti-rejection drugs, maintain good hygiene, and follow recommendations of healthcare team. Everyday precautions: avoid close contact with people who are sick. Take every day preventive actions: clean hands, often wash hands with often with soap and water for at least 20 seconds, especially after blowing your nose, coughing or sneezing, or having been in a public place. If soap and water are not available, use a hand sanitizer that contains at least 60% alcohol. To the extent people avoid touching high touch surfaces in public places, example, elevator buttons, door handles, handrails, handshaking with people, etc. Use tissue or your sleeve to cover your hand or figure if you must touch something. Again, wash your hands after touching surface in public places. Avoid touching your face, nose, eyes, etc. Clean and disinfect your home to remove germs. Practice routine cleaning of frequently touched surfaces, for example, tables, doorknobs, light switches, handles, discs, toilets, faucets, sinks, and cell phones. Avoid crowds, especially in poorly ventilated spaces. The risk of exposure to respiratory virus like COVID-19 may increase in crowded places and areas with poor ventilation and little air circulation. Stay home as much as possible. Consider ways of getting food brought to your house through family, social or commercial networks, and avoid all non-essential travels. Last thing, we hope that Egypt and the entire world will get over this pandemic, and the humanity will survive and will thrive, and we can all with the collaboration between each and every one of us reach the safety first of all by staying home. For those who are not required to go anywhere, please stay home. Let's do our job as physicians and health care workers, and we will get over it, inshallah. God save our country, and God save the entire human race. Thank you so much.